Hey everyone, my name is Dr. Galatea Strong. I'm a physical therapist who got 100% on my boards exam, and this led me to found SPT with Me, which is an NPTE prep platform. If you enjoy what you see and you're studying for the NPTE, check out our courses at sptwithme.com. Now for what you're actually here for, let's talk about what is a dermatome. If you think about the term dermatome, this should be the first image that pops into your head. A dermatome is a specific region of the skin that is primarily supplied with sensory information that's supplied by a single spinal nerve root. So let's break down what that actually means. Let's start off here at the spinal cord level. So think about the spinal cord and its entire column. This is just one segment of this, right? It's a cross section. With dermatomes, we are talking about sensation, and sensation information, sensory information, is registered at the posterior horn of the spinal cord. So information from the skin is sent to this region, the posterior horn. Again, from the skin. So let's work our way to the skin. This is the lumbar spine. Let's say we are talking about a patch of skin that registers sensory information from the lumbar spine, and let's say that it's L4. The L4 nerve root comes out between L4 and L5. Just a reminder, the anterior region of the thigh is the area the L4 nerve gets information from. So this nerve is coming out from the level of L4. But just remember, nerves do not come out looking like this image. It's not just one thick nerve that makes its way all the way to the side of the skin. This is how nerves actually look coming out as a peripheral nerve. A bunch of branches. These little branches then turn into even smaller branches as it makes its way through a bunch of tissues toward the skin to its eventual destination at the skin, which again is right here. So what we just talked about happens at all spinal levels. Let's say T1. T1's going to come out of the spinal cord and make its way towards its specific segment of skin. L3, it makes its way from the spinal cord to its specific segment of skin. T10, C2, it doesn't matter. All of them. Now, the direction that we've been talking about is actually the opposite of how information is sent. A dermatome's direction is not from the spinal cord to the peripheral nerve to the skin. It's the exact opposite. Let's go over the correct route of how sensory information travels. So we start here. Let's say someone pokes the anterior aspect of your thigh at the L4 region. The nerve that receives information from this part, we know it's L4, of the skin is going to send information from this anterior region of the skin along its axon, making its way toward the spinal cord. As this nerve travels through a bunch of tissues to make its way toward the spinal column, it looks like this, a bunch of branches. But eventually, this branch and bundle of nerves is going to ultimately bunch up and make one thick nerve that enters the foramen magnum, which is the opening that the nerve travels through. And once it goes through the foramen magnum, we reach here again. So once it reaches the posterior horn, this information is going to travel up or superiorly through the spinal cord toward the brain to tell the brain that someone or something just touched the anterior aspect of my thigh. Now that we know what a dermatome is, why do we care? We don't learn things just to learn it. It can really help us in ruling out conditions, diseases, injuries, etc. Now think about the ASIA scale. The ASIA scale helps us to identify the level of involvement for those who have gone through a spinal cord injury. In that scale, we test for sensation, right? And the sensation that we test for is literally using dermatomes. We test sensation at C1, C2, all the way down the spinal cord. So it's from the knowledge of where dermatomes are that we can actually do this. We can also identify injuries, such as those with disc involvement. If my disc is affected, obviously depending on the severity of my injury, it compresses my nerves. Not only is my motor nerve affected, but also my sensory nerve. Let's say I don't have an image to go off like an MRI. What I can do is use my knowledge of dermatomes to test out the sensation at certain dermatomal levels and see if it's impaired or not, and this can help me rule in or rule out which specific levels are affected. So let's give an example. Let's say that with my patient, they're coming in, they're having some radiation down the leg. I test their L4 dermatome level. They cannot feel that sensation of me poking their leg, or at least they can't feel it as well. But when I test out the sensation at the L5 dermatomal level, they're able to feel it fine. So maybe this suggests that my L4 disc is protruded. That's the one that's involved. Just an example, it can help you rule in and rule things out. Medical screening. If there are sensation deficits that don't necessarily follow how the dermatomes are, it can be that the condition is something else. For example, arterial claudication. The arteries have no association with dermatomes. So the sensation deficits will not follow the distribution of what a dermatome would be like. So these are some potential applications that we can make use of with respect to knowledge about dermatomes. If you enjoyed the way that this was taught and you truly understand dermatomes now, check out our courses at SPT with me when you're studying for the NPTE. Check out these references for more information.